Hola, buenas tardes. Soy Enriqueta Felip, soy oncóloga del Hospital Vallebrón. Es un verdadero honor para mí participar en esta reunión. Quiero felicitar a la Fundación ECO por la iniciativa y realmente tener la oportunidad de presentar la Keynote Lecture de la doctora Natalie Vaux. La doctora Vaux ha sido fellow en Dana-Farber, en estos momentos es assistant professor en MD Anderson y realmente ha recibido muchísimos honores, premios por su trayectoria profesional, así como tiene muchas publicaciones sobre la predicción de la respuesta a la inmunoterapia. Es un verdadero honor tenerla. So thanks, Dr. Vaux, for being with us today. Thank you for this opportunity to share your presentation with us from TMB to genomic profiling. Please, Dr. Vaux, when you're ready. Thank you for being with us today.
Thank you very much. I will share my screen now. Okay. So thank you very much for that introduction and to the organizers for the opportunity to be here. It's really an honor to be with you giving this presentation, and I'm especially glad to be able to be here with you virtually despite the COVID pandemic that's continuing to affect all of us. As you heard, I'm an assistant professor at MD Anderson Cancer Center and just recently joined their faculty after finishing my fellowship in medical oncology at the Dana-Farber, where I also worked in the lab of Ellie Van Allen. And my clinical focus is on thoracic malignancies, and my research really looks at trying to apply computational approaches to molecular and genomic data sets to understand differential response to therapy. And I'm very excited to be talking to you today about some of our work in trying to understand response to immune checkpoint inhibitors. And I hope some of what we talk about will really echo and amplify the discussion that we were just having in the case presentation. I have no conflicts of interest. So I'm going to spend the first portion of this talk focused on tumor mutational burden, or TMB, which is the genomic feature that's really received the most attention to date. I'm going to talk about why I think it's a relatively limited biomarker, at least at this point, but also why I think we can use TMB as a lens to thinking more broadly about the response to immune checkpoint inhibitors and how we can move from simply trying to apply these to the clinic to reaching a more comprehensive understanding. And I'll then build on this theme by talking about some of our other work in this regard and some of the lessons that we've learned as we've gone through this, before finally talking about how I hope we can use computational approaches to kind of mirror these two aims of both advancing our understanding of biology while also improving our ability to predict clinical outcomes and help stratify patients and improve therapies. So TMB was first implicated in some of the earliest studies that looked for genomic predictors of response to immune checkpoint inhibitors. And these studies were done in melanoma using whole exome sequencing. And what they showed was that patients who had response to therapy tended to have higher mutation burdens than those who didn't. And though these were initially done in melanoma, this finding was soon recapitulated in other tumor types, including non-small cell lung cancer, and somewhat by extension in MSI unstable tumors, which are known to have very high mutation loads. And as I mentioned, these initial studies had used whole exome sequencing to calculate TMB, but around that time, it was shown that there was reasonable correlation between TMB calculated from a targeted next-generation sequencing panel, provided that the panel was of sufficient size. And other data showed that the association between response from TMB calculated by panels was very similar to what we had seen in whole exome sequencing. So here you can see data that had used the Foundation Medicine panel, as well as Memorial Sloan Kettering's IMPACT panel, which show a very similar association with response. And since the publication of those initial studies, there's really been an explosion of research in this field, all trying to understand, to show that TMB associates with response and to think about how we can apply this in the clinical setting. But I think this explosion of research, while it's confirmed that TMB does seem to capture some feature of differential response, something that makes patients respond or not respond to therapy, it's also created a lot of confusion. There have been a number of different assays that are used and have been published, and it's not clear how these different assays relate to each other. And similarly, as these different studies have all offered different guidelines and TMB cutoffs, it's not clear whether these different values arise simply from these different assays or because there's true biologic differences in how we need to apply TMB thresholds in different clinical settings or in different disease contexts. So we were interested in thinking a little bit more critically about how and why TMB actually associates with response. But to do so, we also needed a way to translate a TMB value from one data set to another. So we sought to develop a readily, easily applicable harmonization strategy that we could use in the interim while there are kind of more comprehensive harmonization efforts going on internationally. So to do this, we assembled 4 cohorts of patients who'd been sequenced. 3 of these cohorts represented targeted NGS panels, including the Dana-Farber's Onco panel, Memorial Sloan Kettering's Impact panel, and the Foundation Medicine NGS panel. And we also assembled a 4th cohort of patients who'd undergone whole exome sequencing through the TCGA. And these were all lung cancer patients, non-small cell lung cancer patients, in part because that's my clinical focus, but also in part because there's really been a lot of effort in developing TMB as a clinical biomarker in non-small cell lung cancer. So we also identified 2 sub-cohorts of patients who had been treated with immune checkpoint inhibitors for whom we had outcome annotation as well as sequencing data. And these 2 cohorts were from the Dana-Farber and from Memorial Sloan Kettering. And so we took these 4 cohorts and we first wanted to see whether it looks like the TMB values that these different panels are generating do in fact differ, or these different assays do in fact differ. And so to do this, we calculated TMB in a uniform fashion as the sum of all the mutations divided by the length of the sequenced genome. And then we plotted the distribution of TMB values. And what you can see is that these distributions across these panels are in fact different. And that suggests that the range of values that one assay produces is slightly different than the range of values that another assay produces, suggesting that when we see a value of 10 from one test, we can't assume that that 10 is equivalent to the other test. In thinking then about how we could translate these values across one panel to the other, rather than trying to simply map the values from one to the other, which we found to be a little bit fraught as we got into higher TMB values, we instead took the approach of simply trying to map these distributions onto each other, thereby situating a given TMB value relative to the others in that cohort. And so to do that, we applied a normalizing transformation to these distributions. We standardized them into z-scores. And what you can see when we plot these standardized distributions is that there's now fairly nice overlap. So we then turned to our clinical cohorts to see how this played out, practically speaking. So here you can see first plotted the raw TMB values from each cohort. And what you can see is that you see higher TMB in patients with CR, PR, or with durable clinical benefit compared to those without response, which is, of course, what we would expect. But what we also saw is that the TMB values from the Dana-Farber cohort are all a little bit higher than the TMB values from the Memorial Sloan Kettering cohort, consistent with what we saw on the previous slide when we compared these different distributions. When we then plot the TMB z-score values instead of the raw TMB values, you can see that the response association remains the same, but there's also now nice overlap in the distribution of TMB values across these 2 cohorts, suggesting that this harmonization strategy does convert these into equivalent values. So this allowed us to then merge these 2 cohorts to create a joint cohort of almost 500 patients, which we could then use to more thoroughly interrogate how TMB associates with outcome. So the big question in the clinical application of TMB has been identification of a TMB threshold. And a lot of studies to date have tended to pick a threshold at a percentile cutoff, such as the median or the upper quartile. We were interested in more systematically understanding how TMB relates to outcome over the TMB spectrum. And so to do this, we looked at the rate of durable clinical benefit with increasing TMB cutoffs. And what you can see is that as we increase the TMB threshold value to the indicated percentile, the rate of response does seem to go up. But it also seemed like part of what we could be seeing then is that increasing thresholds are simply enriching for the highest TMB responders. So to get a better sense of how this played out more granularly, we also looked at the rate of durable clinical benefit within these decile groupings. And what we saw when we did this is that indeed the patients with the highest TMBs did seem to have the highest rates of response, and the patients with the lowest TMBs did seem to have the lowest rates. But there's also a lot more heterogeneity in the middle of the TMB spectrum. And this suggests that when you pick a TMB cutoff, say at the 50th or 60th percentile, that tells us more about these extremes and less about how patients immediately on either side of that cutoff are going to do. And we more formally quantified this using a receiver operator characteristic curve. And what you can see is that TMB is somewhat predictive. The AUC here is greater than 0.5, it's 0.6, but you can see that it's not impressively predictive. And somewhat pertinently to the last point, you can also see that there isn't a TMB value that maximizes both sensitivity and specificity. And what that means is that when we pick a TMB threshold, we're always going to have a trade-off in terms of undertreatment and overtreatment. And this, we kind of did some numbers just to see what that looks like here. And what you can see is that as we pick higher thresholds, we do treat fewer and fewer patients without response. So our specificity is increasing, but this comes at the cost of failing to treat more and more patients who would have responded. And so when we think about the clinical application of TMB, we need to be aware that we're always, that there is a cost to applying TMB, and we need to be aware of why we're doing it and what the hope is. And I do want to emphasize that this ROC curve is actually pretty similar to what we've seen in a number of other studies. The AUC of TMB somewhat consistently is in the 0.6 to 0.7 range. So I do think that this is something that, that seems to hold true across many different disease contexts. And I think these considerations are especially important because TMB somewhat inevitably is coming to the clinic. So at least in the United States, we now have an FDA approval that includes TMB. This was true as of June of 2020, so very recently. And this approval is for pembrolizumab across different cancer types in the second line or advanced setting for patients with a TMB greater than 10 as defined by the Foundation Medicine test. And this is based on data from Keynote 158, which was a trial that included 10 different tumor types. The outcome for this study was overall response rate, and you can see here that the response rate in the TMB high group was 30%, but that it increased to 37% with a higher cutoff. And notably in the prescribing text, they also mentioned that for the patients whose TMB were between these two thresholds, the response rate was actually only 13%. And this, I think, is very similar to what I showed several slides back, that, again, it's really more about their extremes than about patients right around these cutoffs. I think in addition to kind of this more general concern about applying TMB thresholds to the clinic, there are also some specific concerns that I have about this approval. So the first is that this is based on response, not overall survival. We have yet to see the final published data, so there may still be more coming, but at least an interim analysis that was presented last year didn't show any overall survival benefit in the TMB high group. The tumor agnostic approval is also a little bit problematic insofar as only 10 different cancer subtypes were included, and some important ones such as breast cancer, prostate cancer were not. And notably, the majority of patients in this cohort of 102 are in these top 3 tumor types for which immune checkpoint inhibitors are already approved. So the tumor types for whom this is a new approval are shown here on the bottom, and the number of patients enrolled in this trial with those tumor types is actually very, very low. And so we unfortunately don't really have any efficacy data on the basis of this as to how how effective pembrolizumab really is in these tumor types. And the concern is that now that we have this approval, this is going to dissuade patients from enrolling in clinical trials where we could more thoroughly understand whether pembrolizumab benefits these patients. And then finally, I've mentioned a couple times my concerns about the TMB cutoff. In addition to the kind of more general philosophical concern, it's also not clear that there is a tumor agnostic cutoff of 10. It may be the case that we need to think about different cutoffs in different disease contexts, both with respect to tumor type and respect to treatment line. But I think also more broadly, as we've been focusing on trying to define cutoffs and implement TMB in the clinic, that's distracted us from thinking about why it is that TMB actually does kind of capture response and why it is that it fails to do so in certain situations, and whether we can learn a little bit more about the context in which TMB is or isn't informative. So in our non-small cell lung cancer cohort, for example, we noted that when we stratified patients by smoking status, TMB only associated with response amongst patients who had a smoking history. The patients who were never smokers, there was no difference in TMB between responders and non-responders. And you can see that TMB was not at all predictive in that clinical context. And even more strikingly, it turned out that the ever smokers who did not respond to therapy still had higher TMBs than the never smokers who did, suggesting that if we want to think about response in the never smoker group, we may need to think about something completely different than TMB, that the biology in those patients may be very different. Some other interesting data came from Charlie Swanton's group in 2016, suggesting that in addition to mutation load, it may be the mutation clonality that matters. So they found that TMB or higher neoantigen burden does distinguish between responders and non-responders, but this stratification became more pronounced when they included more clonal mutations. So it may be that in addition to needing more mutations, it's also important that these mutations be clonal. And we found in another cohort of 250 patients across tumor types, which I'll talk about more shortly, that clonality also seems to associate with outcome. So here you can see that in tumors that were majority subclonal, the rate of progressive disease was much higher than in patients whose tumors were primarily clonal, suggesting that the heterogeneity of the tumor may interact with the mutation load. Similarly, it may be that mutational signature or mutagenic process plays a role. So in our cohort, when we looked at the melanoma patients, we found that rates of response differed by dominant mutational signature, with higher response rates in tumors with alkylating or UV signatures compared to those that did not have those signatures. But when we stratified by these dominant mutational signatures, you can see that, again, tumor mutation burden is no longer associated with outcome. So it could be that part of what TMB is doing here is acting as a surrogate for these mutagenic processes rather than acting as an independent predictor. So my takeaway from this analysis is that I think TMB is actually very interesting insofar as it may be a surrogate for some of these other biological processes. It's not clear to me, at least as of yet, that there's a strong role for TMB clinically, other than kind of helping persuade us in one direction or the other, as we talked about previously. But I think it does suggest that we can learn more about what's going on and use that as a starting point. So taking a step back from TMB, I think what this discussion highlights is the larger point that the response to immunotherapy is probably very complicated, and we can start to use these kinds of frameworks of applying immunogenomic analyses to begin to learn more about and start to, if not unravel, at least visualize this complexity. And I think this will be very important because TMB ultimately is probably only one small part of a very complicated puzzle that dictates which patients are and aren't going to respond. So to give you a sense of some of the way that we've been thinking about this, our approach has been to aggregate patient cohorts that are clinically annotated, where we have good whole exome sequencing data from pre-treatment samples, and then to use these immunogenomic cohorts to try to get at some of these associations. So I already mentioned this cohort of 249 patients with whole exome sequenced tumors, and this is a pan-cancer cohort that's dominated by melanoma, but does also span some other cancer types. And when we when we analyzed these tumors, we made a couple of interesting observations. So the first is that we noticed that there was an association between amplification and cell cycle genes with resistance to immunotherapy, with the caveat, of course, that a lot of these associations were underpowered, even despite the size of this cohort. And, you might say that, well, seeing an underpowered association in one cohort isn't that definitive, but around the same time that our paper was published, there were several other papers in different experimental contexts that also showed an association between cell cycle pathways and anti-tumor immunity. So this, I think, is a good example of how these kinds of immunogenomic cohorts, when paired with other data types, can help mutually reinforce each other. We also noted that P10 deletions seem to associate with resistance to therapy. And again, an underpowered observation here, but with more support from other data, in vitro data that showed an association between P10 loss and decreased anti-tumor immunity, as well as a P10 resistance mutation in a head and neck sample or in a sarcoma sample at the Dana-Farber. But interestingly, this story got more complicated when we looked at the mutational data. So you would expect that PIK3CA activating mutations would also associate with resistance to therapy. But instead, what we found is that these activating mutations tended to associate with response to therapy. But we also noticed that a lot of these activating mutations occurred in the context of an APOBEC mutational signature, suggesting that when we think about these single gene correlates, we actually need to think about the molecular context that they're arising in. And indeed, it turned out that APOBEC in and of itself is also associated with response. So here you can see that the rates of, that in patients with CRPR, the proportion of APOBEC-related mutations is higher than in those with progressive disease. So this illustrates how when we think about these genomic correlates, we also need to situate them in this whole picture of these interactions. EGFR, I think, is also interesting in this way. So there's been a lot of discussion in the lung cancer community that EGFR mutant non-small cell lung cancer tends to be less responsive to immunotherapy. But EGFR, of course, associates with lower TMB. These are lower mutated tumors. And interestingly, EGFR in our cohort also associated with a higher proportion of subclonal mutations. And as I mentioned a couple slides back, subclonality also seems to associate with worse outcomes in response to checkpoint inhibitors. So we still have a lot to learn whether the EGFR, something about the biology of the EGFR mutation, the mutational history, or the intratumoral heterogeneity of these tumors is driving the negative response association that we're seeing. We also need to think about the clinical context that these mutations are arising in. So this is a study published by my colleague, Dave Liu, of a cohort of about 150 melanomas that were whole exome sequenced before receiving treatment with anti-PD-1 therapy. And here you can see the kind of typical response association between TMB and outcome, with higher TMB and responders compared to progressors. But when he stratified TMB by melanoma subtype, you can see that this association went away. And in fact, similar to what we saw amongst the smokers and the never smokers, it turned out that patients with cutaneous melanomas who progressed still had higher TMBs than patients with mucosal or acral melanomas that responded, suggesting that these clinical features also need to be considered when we think about the genomic biomarkers. And indeed, this cohort ended up being very interesting because it also helped us discover that sometimes there can be hidden clinical variables that are shaping the molecular data that we look at. So this was an interim analysis of transcriptomic data where we saw this very cool clustering between tumor intrinsic and immune features. And initially, this is Ellie Van Allen's words, this was very exciting. We said, oh, wow, there's this latent structure. It's correlating with response. Awesome, we're done. But then when we looked more closely at the data, it turned out that the driver behind this structure was actually the presence or absence of prior treatment with ipilimumab. So it turns out that we needed to take that clinical feature into account before we could analyze the genomic and transcriptomic data. And all of this points to, I think, the complexity of the problem that we're dealing with, but also how we can start to pick apart this very tangled knot doing these kinds of analyses. And I think the way forward is leveraging the more advanced computational approaches to help us both continue to integrate and understand and identify these different variables while also integrating them into more comprehensive and ultimately more accurate predictive models. So in the melanoma data set that I just mentioned, once we realized that we needed to stratify by pretreatment status with ipilimumab, we were then able to build two distinct and reasonably good predictive models. So here you can see the AUC of these two models was 0.9 and 0.76, and this was using a logistic regression classifier approach. And this is better than what we had been seeing with PD-L1 or TMB in other clinical contexts. But it's also true that these feature selection approaches help us identify which molecular features are the most predictive of response. So in the IPI pretreatment group, the features that emerged were MHC class II expression, LDH, and the presence of a lymph node metastasis, whereas in the IPI naive group, more genomic features such as heterogeneity, ploidy, and purity ended up being the most predictive. In our lung cancer cohort, we tried training several machine learning models just on TMB, and we got an AUC of 0.6, very similar to what I showed previously. But when we tried training different models on a list of 20 genes, the AUC improved to 0.7. And this is still very early days in this work, but it suggests that we can both improve our predictive capability by including more variables, while also telling us that something about these gene mutation status in these genes does seem to associate with outcome in a way that can help us build additional hypotheses to test in other settings. A similar work was presented at World Lung last year by the Catherine Arbour from Memorial Sloan Kettering. So Memorial Sloan Kettering has a clinical cohort that includes both genomic data as well as lab features and clinical features. And when they applied a logistic regression classifier, they were also able to build a model with an AUC in the 0.7 range. And interestingly, again, this approach allowed them to identify features that seemed to be more predictive of response. TMB notably was not one such feature. It did not correlate with outcome at all. But you can see that their final model includes a mix of genomic and clinical features. So genomic features such as EGFR mutant status and STK11 were included, but so were lab values such as lymphocyte count and platelet count, as were clinical values such as smoking history. So I think these kinds of approaches can be really illustrative in helping us hone in on which molecular or clinical features are most important to then to study further. Now, this kind of modeling is still in early days. A lot of the models that I presented today still need to be validated in external data sets. And ultimately, we still need larger and better cohorts. Our power to detect single gene correlates of response is very limited to those mutations that are very prevalent. And as we start to look at less common alterations or less commonly altered pathways, we're ultimately going to need data sets in the 1,000 plus range. And this is something that we're working on, and we invite anybody who's interested to collaborate with us on this, because I think this is ultimately going to need to be a joint communal scientific effort. So in conclusion, I think I've emphasized several times that I think TMB as it stands has limited utility as a clinical biomarker, though it certainly can in some contexts be informative. But I think more broadly speaking, it's actually interesting insofar as it can highlight important underlying biology that's worth investigating further. And I think more broadly speaking, the path forward is going to be some kind of iterative effort that uses large genomic and patient databases paired with functional validation and recurrent and iterative analysis to identify new biological pathways that underlie differential response. And this effort will be helped by advanced computational approaches that can help integrate multiple features into more sophisticated models, thereby honing in on the relevant biology, but also developing predictive models that work better and that can then further guide therapy. So with that, I'd like to thank my many collaborators at the Dana-Farber in the Van Allen Lab and here now at MD Anderson, as well as our collaborators across the country and my funding sources as well. And I'm going to stop sharing my slides now, and I'm happy to take any questions.
Thank you, Dr. Vokes, for the excellent presentation. So this is a keynote, so no clear question and answer session has been planned. But if I can ask you a question. What is your opinion about liquid biopsy and TMB? Any role in the treatment for the patients or not? What are your thoughts on that?
So I think that on the pre-treatment side, so in terms of using blood TMB to calculate TMB and define treatment settings, I think what we've seen is that blood TMB seems to work as well as tissue TMB from a predictive standpoint, which is to say it works kind of. I think that the mapping tissue TMB onto blood TMB is a little bit problematic insofar as you capture different mutations and the sensitivity may differ in different clinical contexts. But I think we've seen that from a predictive standpoint, the overall response association seems to be as good. And if we're going to be using TMB in the clinic at all, I think it's certainly reasonable to use blood TMB in that setting. As I've mentioned, I don't think that TMB solves all of our problems with respect to stratifying patients, and I don't think that blood TMB is better than tissue TMB in that aspect, but I think it's a reasonable tool. I think there's also the question on the other side as to how we can use circulating tumor DNA after we started treatment to assess response and to define response kinetics. And I think we're still learning more about that, but I think that may end up being very valuable in terms of allowing us to say whether a patient has truly responded or not, and thereby either intensify therapy or potentially stop immune checkpoint therapy earlier, and thereby avoiding complications that may arise from more prolonged, unnecessary treatments.
And a second question is this kind of genomic profilings. Should we do this test in the archival tumor? Is there any role for rebiopsy and to repeat this kind of test in the patients, for example, with lung cancer?
So I think there is growing data that shows that PD-L1 staining and TMB are heterogeneous across tumor sites and treatment contexts. But I don't think that right now we've defined which value is the value that matters more. Is it the metastatic value or the initial biopsy? And I think that, again, because TMB and PD-L1 are only a little bit predictive, I think that little bit that we get from either of those biopsy contexts tends to be good enough, or we at least need to study more whether we're misclassifying patients when we use an archival specimen versus a new specimen. So I think right now the data isn't there to argue against using the old specimen if that's the only thing that's available. From a research standpoint and kind of a real world data standpoint, I like to biopsy patients as often as I can and as often as they'll let me, because I think that does give us more data to then put into these data sets to analyze. But from a treatment standpoint, I don't think we know that one type of biopsy is better than another.
Okay, so thank you again for the presentation. Muchas gracias a todos por estar aquí hoy. Gracias a la Fundación ECO por organizar esta reunión. Y gracias de nuevo a la doctora Vokes por la excelente presentación de hoy. Gracias a todos.